Welcome to the deep dive. Today we're really cutting through the noise, getting into something critical.
Yeah, diving straight into something that's, well, both urgent and incredibly promising.
Exactly. We're talking about that revolutionary intersection of advanced engineering, AI.
And women's health. It's fascinating, isn't it?
It really is. Because for decades, so many areas, think pregnancy complications, PCOS.
Right. They've just been historically under-researched, often using generalized data.
But the sources we're digging into, they show this massive technological pivot happening right now.
Yeah, you've got computational scientists tackling problems, mechanical problems, data problems that, traditional biology just couldn't really touch before.
So that's the core mission for us today, for this deep dive. We want you to understand exactly how these new computational tools are working.
Things like digital twins, machine learning, advanced imaging analysis.
Yeah, how they're creating healthcare that's more personalized, more proactive, and actually genuinely equitable.
It's about moving beyond those traditional biomedical approaches.
We're basically giving you a shortcut to see how the future of healthcare is being engineered, right now.
And the sources are quite diverse engineering centers like WashU on maternal health.
High-level clinical views on AI and imaging from places like JAMA.
And even systematic reviews looking at machine learning for diagnosing things like PCOS. So a real cross-section.
Okay, let's unpack this. We really have to start with the urgent crisis, which is maternal health, particularly in the U.S. The sources we looked at paint a truly stark picture. Maternal mortality rates, they're going up, not down.
Yeah, it's quite shocking. And the racial disparity is profound.
Black women are facing a 3 times higher rate of maternal mortality compared to white women. It's staggering.
And it's not old news either. Reports from 2020, 2023, they show this situation is actually worsening.
Worsening, why?
Well, the sources suggest it's partly due to political shifts, and also the fallout from COVID-19 seems to have exacerbated things.
And we need to be clear about what maternal health even means here, right? It's broader than people might think.
Oh, absolutely. Clinicians now define it properly as the entire 40 weeks of pregnancy plus a full year postpartum. That's crucial.
A whole year after birth.
Yes.
Yeah.
And the physical impacts, the sort of mechanical effects of pregnancy, can actually show up decades later.
20 or 30 years down the line, like what?
Yeah. Things like pelvic organ prolapse, which can significantly impact quality of life. It's often a long-term mechanical consequence.
Okay, so that mechanical aspect, that's where the engineers come in.
Precisely.
Take something like preterm birth. It affects, what, about 10% of all pregnancies?
Around that, yes. And that rate has been stubbornly, tragically stationary for years. No real improvement.
And if you look at the really severe complications, uterine rupture, preeclampsia, short cervix.
They all have a clear mechanical or physical component, something engineers are uniquely equipped to analyze.
So it's not just biology failing, it's potentially structure, materials, engineering problems.
Exactly. These are structural and material failures too.
Yeah.
But the challenge has always been, how do you study this?
Because pregnant women are a highly vulnerable population. You can't just run experiments.
Right. Large-scale invasive experimentation is often undesirable, sometimes unethical, which is why these computational tools are so vital. They offer another way.
And that leads us to a really key moment, a legislative shift mentioned in the sources. The FDA Modernization Act from late 2022. Why was that so important?
Yes. It basically formalized the pathway for using in silico approaches. Making computational modeling. It allows these models to be used alongside, or sometimes even in place of, traditional animal testing for approving drugs and devices.
So before it was mainly animal models, then human trials.
Pretty much. Human trials were the gold standard, animal models the main precursor. Now, these sophisticated computer models can actually help speed up research in these really sensitive areas.
Giving scientists safer, faster insights without necessarily putting humans at risk early on.
Exactly. It's a pathway to understanding that wasn't really there before, officially.
Okay, so that perfectly sets up one of the most exciting tools, the digital twin. We hear this term a lot. How does it work for, say, a pregnant patient?
Right, so a digital twin in this context is essentially a virtual copy of the patient.
Yeah.
It's patient-specific, it's real-time.
A virtual replica. How do you build that?
Using data that's already being collected safely and easily, routine clinical ultrasound scans.
Okay, the standard scans everyone gets.
Exactly. We take the geometry, the tissue elasticity estimates, measurements from those low-risk scans, and build a dynamic virtual model of that specific patient's uterus, cervix, everything relevant.
So it becomes like a virtual lab.
Precisely.
Where you can run simulations you could never, ever do on a real person.
That's the power. Take the risk of uterine rupture after a C-section, a major concern.
Yeah.
Engineers are using these techniques called finite element models, or FEM, to simulate what happened.
Okay, finite element models. Break that down for us. Sounds complex.
It is technical, but the idea is pretty straightforward. Imagine trying to figure out how much pressure something complex, like a tire, or in this case a uterus with a scar, can handle.
Okay.
You can't just model it as one solid block. FEM breaks that complex shape down into thousands, sometimes millions, of tiny interconnected pieces or implements. Think of it like building with tiny virtual Lego bricks.
Ah, okay. Little bricks making up the whole structure.
Exactly. Then the computer uses physics equations to calculate the stress and strain on every single one of those bricks when you apply simulated pressure, like the pressure during labor.
So you can predict exactly where it might fail.
Yes, where the weak points are and under what conditions failure might occur.
That's an amazing analogy. So applying FEM to C-section scars, what did the simulations actually find?
Well, really interestingly, they validated things clinicians already knew from experience, but with much higher precision.
Like what?
Like, they confirmed that the older style sagittal or vertical C-section scars, they create regions of significantly increased stress compared to the modern low transverse scars.
Which is why surgeons switch techniques.
Right. But more critically, the models showed that even tiny defects or thin spots in the scar tissue dramatically increase the stress concentration right there.
So you can pinpoint potential vulnerabilities before a problem happens during labor.
That's the goal. Proactive risk assessment based on the individual's specific anatomy and scar.
Now, building these models for something really complex, like predicting preterm birth, that involves dozens of factors, right? Not just mechanics.
Absolutely. Multifactorial.
So you need more than just scans. You need massive amounts of detailed patient data. Where does that come from, given the ethical constraints?
Yeah, that's a huge bottleneck. And this is where synthetic medical record data comes in. It's become a really powerful tool.
Synthetic data, so not real patient data.
Correct. Programs like the one at Washington University called MD Clone generate large, completely artificial patient data sets.
Artificial, but useful.
Very useful because they're designed to be statistically identical to real patient populations. They mirror the complexities, the demographics, the correlations found in real data, but without any link to actual individuals.
Which gets around consent issues for massive data sets.
Exactly. It removes a huge hurdle for studying complex, multifactorial problems like preterm birth, where you need data from thousands, even millions of theoretical patients.
And thinking back to that racial disparity we started with, how does synthetic data help address that? Because bias in data is a huge problem in AI.
It's actually a direct way to combat historical data bias. Since we know Black women face higher risks, researchers using MD Clone can deliberately create synthetic data sets that accurately represent larger numbers of these underrepresented groups.
So you're not limited by whatever historical data happens to exist, which might be skewed.
Precisely. If real-world data sets are missing certain populations or don't have enough data points, you can synthetically generate a balanced, representative data set. This ensures the predictive models built on that data are actually robust and equitable for everyone, not just the majority population they might otherwise be trained on.
That's genuinely powerful. Engineering meeting the crisis not just with better models, but fairer models.
It has that potential, yes.
Okay, let's shift gears slightly. We've talked about modeling pregnancy, but AI is also aiming to act as a clinical co-pilot across a woman's entire life. And there's a known gap there, isn't there?
There definitely is. It's often framed as the health span gap. Women tend to live longer than men, statistically.
Right, longer lifespan.
But unfortunately, they often have a shorter health span. They spend more of those later years living with poor health or disability. AI is being deployed in various ways to try and, well, shrink that unhealthy window.
And the most obvious place people see AI in medicine now is imaging, right? Like AI as a second reader.
Yes, for things like mammograms, breast ultrasounds, MRIs, it's becoming more common.
What's the goal there? Is it just finding more cancers?
That's one goal, yes.
Yeah.
To potentially catch slightly more cancers that maybe a radiologist, perhaps fatigued or rushed, might overlook. But there's a second goal that's arguably just as important for the patient experience.
Which is?
Reducing false positives. Those callbacks when something looks suspicious but turns out to be benign.
Yeah. Those cause immense stress, lead to unnecessary biopsies, more tests, more costs.
Exactly. So the aim is twofold. Find a few more cancers, but also significantly cut down on those stressful false alarms.
Now, I know breast imaging is particularly tricky for AI. Why is that?
It really comes down to subtlety. Cancers on a mammogram can be tiny, 5-6 millimeters, little specks.
Especially in dense breast tissue, right?
Especially then, yes.
Yeah.
Becomes a true needle in the haystack problem. And while the AI models are getting better, incredibly fast actually, but our sources suggest that currently their accuracy often still doesn't quite match that of a really seasoned, experienced human radiologist.
So it's a helper, a co-pilot, not a replacement yet.
Definitely a support tool at this stage.
Okay, here's where it gets really interesting. What I found truly disruptive in the research is how AI is using scans taken for totally different reasons. This idea of opportunistic screening.
Yes, this really changes the game. It redefines what a clinical scan is.
How so?
Well, previously, you got a scan for one specific reason. You broke your arm, you get an x-ray of the arm, you have lung symptoms, you get a chest CT.
Makes sense.
With opportunistic screening, the AI works in the background. It looks at that scan you got for, say, a cough, and it automatically screens it for other health markers that just happen to be visible in the image. It turns a focus scan into a kind of mini health checkup.
Wait, so you're telling me that CT scan I might get if I don't know, fall off a ladder or get into a minor car accident, it could also be secretly checking my bones or my heart. That's kind of mind-blowing.
Yeah, it is revolutionary.
Yeah.
And it uses data that was always there on the image, technically, but just wasn't analyzed because it wasn't the primary purpose of the scan.
So what kind of things is it looking for? The research highlighted 3 main examples, right? On things like chest CTs.
That's right. 3 key opportunistic findings from, say, a standard chest CT.
Okay, give us the rundown. Number 1.
First, bone density. The AI can look at the parts of the thoracic spine, the upper back bones that are visible on the chest scan, and estimate bone density.
Providing a quick check for osteoporosis risk without needing a separate DeGuessa scan.
Exactly. A secondary assessment for a major health issue for aging women, basically for free from an existing scan.
Okay, number 2.
Second, it looks for calcium buildup, calcifications around the heart, and in the major arteries visible in the chest.
Which is a marker for
arterial sclerosis, hardening of the arteries. It acts as a direct, quantifiable surrogate for heart disease risk.
Wow. Both of those are often silent killers, things you don't know you have until something major happens.
Precisely. And the third one is also fascinating. Muscle health.
Muscle health from a chest scan.
Yeah, the AI measures the amount and quality of the chest and back muscles visible in the scan. This relates to a condition called sarcopenia, which is age-related muscle loss.
And why does that matter?
Well, sarcopenia is linked to frailty, poor recovery from illness or surgery. Surprisingly, the amount of muscle measured on these scans turns out to be a strong predictor of how well patients will recover after major surgery, for instance.
So one scan ordered for maybe pneumonia suddenly gives you insights into bone health, heart risk, and even potential surgical outcomes.
That's the power of opportunistic screening. It's turning a single image into this high-level summary of a patient's potential long-term risks. Proactive, preventative insight.
That proactive idea leads us perfectly into our next area. AI tackling one of the most common and frankly often frustratingly managed endocrine disorders.
Ah, yes, Polycystic Ovarian Syndrome, or PCOS.
It's huge, isn't it? The prevalence is staggering.
It really is. It's the most common endocrinopathy in women of reproductive age. Estimates range from maybe 4% up to 20% of that population.
Which translates to millions.
Over 66 million women worldwide, easily. And the public health burden is immense. In the U.S. alone, the sources cited nearly $8 billion spent in 2020 just managing symptoms related to PCOS.
And diagnosis can be tricky, right? The criteria aren't always consistently applied. Seems like a perfect job for AI.
It does, and the performance we're seeing in the research is pretty incredible.
How incredible?
Well, when the studies use standardized diagnostic criteria like the Rotterdam criteria or the NIH criteria,
Okay, the established guidelines.
the AI and machine learning models are showing consistently high diagnostic and classification performance. We're talking diagnostic accuracy often between 89% and, in some cases, 100%.
Wow, up to 100% accuracy.
In certain studies using specific models and clean data, yes.
The sources mention one specific model, CystNet.
Yeah.
What did that achieve?
All right, CystNet uses deep learning, specifically analyzing ultrasound images of the ovaries. Using what's called an ensemble ML classifier approach, basically combining multiple models, it achieved accuracy up to 97.75% for detecting PCOS features on ultrasound.
Near perfect performance on that specific task. That's impressive.
It is.
What I always find helpful, though, is when these models tell us why. Which features did they find most important for making that PCOS diagnosis?
That's key for understanding, isn't it? The ML models consistently highlighted a few key predictors. The ratio of follicle-stimulating hormone to luteinizing hormone, known as FLR, that's a hormonal marker.
Okay.
Then the follicle number in the left ovary, FNL, that's a physical characteristic seen on ultrasound.
Right, the cysts aspect.
So technically small follicles.
Oh.
And third, the patient's reported menstrual cycle length, a key clinical symptom.
So it's combining hormonal data, physical imaging data, and patient-reported symptoms.
Exactly. It reinforces that PCOS is multifactorial, and the AI is good at integrating these different data types.
Okay, that sounds incredibly promising. High accuracy, clear predictors, but there's always a but, isn't there?
Usually.
Our sources also included a pretty sobering finding from systematic reviews about the quality of the data used in many of these PCOS AI studies.
Yes, this is the critical data quality gap. It's a major caveat. Despite those really impressive accuracy numbers we just talked about.
Yeah.
Only about a third, just 32% of the AML studies on PCOS that were reviewed actually used those standardized consensus diagnostic criteria like Rotterdam or NIH.
Only a third. So what were the other 2/3 using?
Varied criteria, sometimes poorly defined, sometimes just based on the local institution's practice.
Yeah.
Not standardized.
Okay, what's the practical danger there? If a model boasts 99% accuracy, but wasn't trained using the standard definition of the disease.
The danger is huge, and it ties right back to our earlier discussion about equity and bias.
How so?
If your model is trained on non-standard, maybe poorly defined, or perhaps just very small, homogeneous data sets, it risks misclassification when you try to use it in the real world.
So it might work perfectly on the data it saw during training.
Exactly. It might be incredibly accurate for diagnosing PCOS in the very specific, maybe narrow group it was trained on. But deploy it in a diverse general hospital setting, it could completely fail.
Or worse, introduce new biases if it performs differently on different ethnic groups, for example.
Precisely. This lack of standardization in the training data severely limits how reliably these very promising models can actually be translated into everyday clinical practice right now.
Which brings us neatly to that final hurdle, bridging the gap. Getting this amazing tech out of the lab and into the clinic effectively and fairly. We know data diversity is one issue, but where else are the bottlenecks in actually integrating this AI into healthcare?
Well, another point the sources raised, particularly for PCOS studies, was the setting. A huge majority, 71% of these AM studies were done entirely outside of real clinical settings.
So in research labs, university departments.
Yes, they're highly accurate under controlled lab conditions, but they haven't been properly stress tested in the, let's say, chaotic, time-pressured environment of an actual clinic with real patients and workflows.
Which limits their practical relevance for the doctor trying to make a decision right then and there.
Definitely. That real-world validation is still missing for many applications.
But it's not all challenges. AI isn't just a tool for rich countries with big hospitals. It can actually be an engine for global equity, right? How is it helping in places like low and middle income countries, LMICs?
This is where it gets really exciting, actually. It's enabling disruption through decentralization.
Okay, what does that mean?
Think about breast cancer screening again. In many parts of the world, access to high-end fixed mammography machines is just zero. It's not available.
Right.
So AI is being used creatively to train non-medical personnel community health workers, for example, to use point-of-care ultrasound, PCOS.
That's the little handheld ultrasound probe you can connect to a smartphone.
Exactly. Super portable, relatively low cost.
So a health worker uses the smartphone scanner and the AI.
The AI helps guide the user to get good quality images, which is hard even for experts, and then it provides an immediate, reliable, first-path interpretation of those images.
Wow. So AI is validating scans done on a smartphone by someone without years of radiology training.
Essentially, yes. It allows for vital preliminary screening to happen in rural clinics, remote villages, places where there was simply no screening infrastructure before.
Yeah.
It's helping build healthcare capacity from the ground up.
That's truly disruptive, using AI to leapfrog the need for massive centralized infrastructure. Okay. So, wrapping this all up. So, what does this all mean? Where does this leave us?
Well, we've seen some incredible breakthroughs, haven't we? Computational models from engineering helping to design safer pregnancies, maybe predict risks like uterine rupture.
Yeah, the digital twin idea.
Then there's AI acting like a super scanner, offering proactive whole-body insights through that opportunistic screening on routine scans.
Checking bones, heart, muscle health almost incidentally.
And then machine learning, achieving near-perfect diagnostic accuracy, at least in studies, for really common, burdensome conditions like PCOS. The technology itself is proving incredibly powerful.
Demonstrably effective, at least in specific contexts. The challenge now, moving forward, it doesn't seem to be if the tech can work anymore.
No, I agree.
It's about how we embed it responsibly, ethically, equitably into actual day-to-day clinical practice.
Right. We need much more collaboration between the medical world and the computational science world, bridging that gap we talked about.
We absolutely have to prioritize explainable AI, XAI, right? Models that aren't just black boxes.
Yes, especially to tackle those issues of data bias, the lack of standardization, and build clinician confidence.
Which leads to the final provocative thought, something for you, the listener, to really mull over.
Given that these AI models can achieve such high accuracy, potentially even outperforming humans in specific diagnostic tasks, and given the urgent need for better tools to tackle massive problems like maternal mortality disparities, what specific steps, what mechanisms beyond just publishing papers with high accuracy scores?
What's needed to build the necessary trust?
Exactly. Trust from the clinicians who need to rely on these tools for high-stakes decisions, but also, crucially, trust from the diverse range of patients whose health and lives ultimately depend on them working correctly and fairly.
How do we build that bridge of trust? That really feels like the final frontier to make these amazing technological breakthroughs a universal reality for women's health.
It truly does.
Thank you for diving deep with us today. We'll catch you next time.